We are super excited to welcome Dr. Manish Kadian to today's webinar. Thank you so much, Dr. Kadian, for taking the time to speak with us. Dr. Manish Kadian is a board-certified nephrologist with Columbia Nephrology Associates in Columbia, South Carolina. Originally from India, Dr. Kadian earned his medical degree from JMF's A.C.P.M. Medical College. He later completed his residency in internal medicine at Wright State University in Ohio, where he developed a strong foundation in managing complex medical conditions. Following residency, Dr. Kadian then pursued a fellowship in nephrology and transplantation at the Medical University of South Carolina, gaining specialized expertise in kidney disease and transplant medicine. He is board certified in both internal medicine and nephrology and is an active member of several professional organizations, including the American Society of Transplantation, American Society of Nephrology, and the American Medical Association. He has a particular interest in kidney transplantation and is dedicated to providing individualized, high-quality care for patients with chronic kidney disease and transplant needs. At Columbia Nephrology, Dr. Kadian is known for his patient-centered approach and commitment to advancing kidney health throughout the Midlands region. Dr. Kadian, thank you for joining us. We're excited to hear from you. Is there anything that you'd like to add to your introduction and share about yourself?
I thank you very much for having me, and I appreciate those kind words. I think you described it really well. I'm just excited here to sit and talk about nephrology and hopefully answer some questions and misconceptions.
That's really exciting. We're very happy to have you here. So I'll begin by just asking you some questions, and then we can go ahead and see if anyone else has questions after that as well in the chat or afterwards. So to begin with, could you please give an overview of your role? What is nephrology? And specifically for your role, what is transplant nephrology?
So wanted to tell a little bit about nephrology before we dive into transplant nephrology. So nephrology is study of nephron. Nephron is a working unit in the kidney. We have close to 1 million nephrons in each kidney. And kidney deals with acid-base issues, our electrolytes, it gets rid of waste products, medications, it makes some hormones as well. So when we start to develop kidney disease, we start to see imbalances in those. Kidney transplant is typically when kidney function goes below 20%. And the patients are listed for kidney transplant. And when they get the kidney, they are on immunosuppressive medications. Those are the medications to suppress their immune system so that it does not reject the kidney that is in their body. So that would be like a brief overview of nephrology and transplant nephrology.
Okay. And are there specific types to nephrology? Is it mainly just like a regular nephrologist and then a transplant nephrologist? What are the other types that there are there?
Yeah, so we have general nephrology as the main. Then we do 1 year of transplant fellowship. So then we become transplant nephrologists. There are certain programs across the country where they give extra 6 months to a year of intervention training as well. So these are the physicians who put dialysis catheters, they clean out the fistulas, and grafts. Then few places also provide us with glomerulonephritis GN fellowship. That is 1 year after general nephrology fellowship. And I think there are 2 or 3 programs where there is an ICU or intensivist fellowship after general nephrology fellowship. But majority are general nephrologists. They are close to 13,000 in the United States. And then you have variations of general nephrology plus transplant, general nephrology plus intervention, and very, very few that are general nephrologist and intensivist.
Okay, thank you for that introduction. Speaking of fellowships, could you walk us through your journey into medicine from college to nephrology and then your specific transplant fellowship? What were the key turning points, and what do you think led you to specializing in kidney care?
Oh, so I did my medical school from India back in the late 1990s. So it was a different era. Did not have websites or computers, still went to library. We still had paper exams. So that was a different era. But I think one thing that I remember was when I got residency here. It was my first day as an intern, and I remember feeling very proud about it, that I felt that I have achieved something, which was very short-lived because I was an intern, and got into the rigmarole of internal medicine internship, which is very taxing, first year especially. We are trying to learn the EMR system, which is electronic medical record, at the same time trying to take care of the patients, at the same time trying to read. Um, we are quote unquote the working horse of the team. Um, so that 1 year felt very exciting. It was brutal. It was I learned quite a bit. Second year is where we start to have some clarity, and at least that's how I felt. Our first year was very intense in ICU and internal medicine ward. We got just glimpse of subspecialties. Second year is where we started to go into subspecialty rotations 1 month at a time. And when I did my nephrology rotation there, I felt that this is something that I could do for the rest of my life. Acid base and electrolytes excite me, and that was the starting point of being interested in nephrology. Um, Late second year, I got to work with an infectious disease specialist who was a transplant infectious disease specialist. And he was seeing patients who were kidney transplant patients, liver transplant patients, heart transplant patients in an outreach clinic in Dayton, Ohio. So patients would be coming from different places. And I got to work with him. And he was an excellent mentor. Even though we worked for a week, I still remember his teachings. And that got me thinking more into transplant. And the more I read, the more interested I became. And then at that time, this was 2010, we would have to apply for fellowship in second year of residency. So I did that, and I was looking for places that do general nephrology and transplant nephrology together. So that limited what I wanted to, where I wanted to apply, but also I started applying in places that had high volume. So that really helped me at that time. And then 2012 started my general nephrology fellowship, another eye opener, a different role. I did 1 year of hospitalist between my general nephrology and transplant nephrology. So going from a primary provider of the patient to a consultant was a change, focusing more on just the nephrology part of the patient care. Um, and I did a couple of months of transplant during my general nephrology fellowship. Was super excited about it, and finished my general nephrology and then transplant in 2015. And then this was my first job at Columbia Nephrology, and I've been here ever since.
That's wonderful. Thank you so much for sharing your story. Can I ask, what does a typical day look like for you as a transplant nephrologist? What are the different roles that you have, and how do you manage to balance them?
So it's a little different here because we don't have a primary transplant center associated with our practice. So it's not where I'm seeing an active transplant patient pre or post-op within 24 to 48 hours. So I typically do see transplant patients in my transplant clinic. They are anywhere from 1 month to my oldest patient got transplanted in 1977, and it is still working. So the older the patient goes, the older the transplant, the longer the immunosuppression, the different kind of medical issues they start to develop. So I see a wide variety of transplant patients in my transplant clinic. Um, I typically our day is very structured, and we have specific days for specific things. So like today, I had transplant clinic in the morning, and I do home hemodialysis as well. So in the afternoon was my home hemodialysis clinic in one of the dialysis units. Um, Typically, we do anywhere from 1 to 2 weeks of inpatient. We are in the hospital in the morning between 8 and 12. See all the new consoles, see all the admitted patients, and then in the afternoon, we are in the office. And then I have dedicated CKD clinics where we do CKD patients, see CKD patients. We see electrolyte abnormality issues, some genetic issues. Um, I'm the medical director of a dialysis unit in Camden, so I go and round there twice a month. So those are also dedicated and separate days.
Okay, so it seems like your schedule is more flexible rather than structured. Are there, is there flexibility depending on the patient load, or how does it work when you see patients after their transplants? How long do you stay with them for?
Um, there is no flexibility in the schedule per se. Um,
Okay.
if we are if we are overwhelmed with the number of patients, then we can get extra help. But it is pretty structured. So inpatient service, it's 8 to 12 in the morning. We got to get it done. If it is too many patients, we can ask for help. Maybe one of the other providers can come and help us out because we have clinics starting at 1:30, office starting at 1:30. So there is not much flexibility. We need structured time for all the activities, all the different kinds of clinics that we do. So our schedule is set 3 months in advance. Yeah. So I cannot ask for vacation for next week. It's done.
Wow, that is very cool, but that's really interesting to hear. So thank you for sharing your perspective. Looking back, what has surprised you the most about your role? Are there any misconceptions or challenges within your field?
Um, the biggest thing that surprised me after I started my job was how good patient feels after they start dialysis. Not that they felt any bad when they did not, but then they realize how toxic they were, and how well they feel after dialysis. Majority of the patients, their appetite comes back, they can breathe better, their blood pressures improve. So I think that was the biggest surprise. As far as misconceptions go, there's a lot of misconception around dialysis, a lot of misconception around transplant. Um, when you look at the data, USRDS data, they talk about typical survival of 50% of patients survive 5 years into dialysis. And that scares some people. Some should be scared rightfully because they are very sick. They have other medical problems as well. But it also scares people who will do better on dialysis to the point that they can get transplanted. So that is one thing where we have to sometimes tease things out a little bit with the patients. Um, the misconception that I found with transplant was bad news travels fast, right? So anybody who died after getting transplant, anybody who got really sick after transplant. I have few young patients in my dialysis units who don't want to get transplanted because of that. They feel that they're going to die if they get transplanted. So those are some of the barriers and misconceptions. Sometimes it is easy to convince and get over those barriers, and sometimes it is difficult. With those two patients, I've been talking to them for 8 years now, uh, and I've still not been able to convince them. So it's a challenging field. It has its own rewards as well, but it has its own challenges too.
And could you speak on those challenge or those fulfilling aspects of your specialty that students might not necessarily expect?
Yeah, so the first one is let me start from start, I guess. So when a patient comes to us, they assume the worst because they're seeing a kidney doctor. Kidney doctor equals dialysis, which is not true. So the when I see just today I saw a young guy, 49-year-old, started crying with his wife right there when we started talking about kidney disease. But we also talked about that his kidney function is at 35%. We're not talking about dialysis right now. Dialysis is when it is below 15%. So there is some risk factors we need to take care of today. He has done well to deal with some of that. So it is very satisfying to tell them and then see the relief in their eyes. Um, Sometimes there are reversible causes, as simple as stop taking NSAIDs, Advil, Aleve, ibuprofen, Motrin, goody powder, BC powder. Sometimes it is people are doing cleansing products that are bad for the liver and kidney. Some of them are trying to lose weight by taking over-the-counter diuretics or taking diuretics from other countries. So those are easy fixes. So that is where we, at least I feel a sense of satisfaction when you can stabilize their kidney function or even improve. Then comes the second stage in patients who are progressing, um, uh, kind of holding their hand, giving them all the information they need, making sure they're prepared for the biggest change in their life, which is dialysis. Making sure they do okay, making sure they get all the surgeries that they need so we can start dialysis outpatient, not in an emergency situation in the hospital. So when that happens, that gives me a lot of, I feel proud and very satisfied that I did contribute to the health of the person, of the patient. And finally, patients who can get transplanted, getting them on the list of transplant and getting them transplanted. That is the most excellent feeling. Seeing them in the office when they are transplanted, giving them high fives. I think that is the most amazing feeling that I can speak of. Yeah.
It's amazing. I can only imagine that feeling, seeing your patient succeeding through their treatment. That's amazing. So thank you for sharing. So I know that we've kind of touched upon some of those kidney myths. I have four different that I'd want to share with everyone, and I'd appreciate your help in helping clear those kidney myths. So the first one that some people might hear is that kidney disease is rare. What do you think about that one?
So 1 in 6 people worldwide have kidney disease. 1 in 6. And 80% of them don't even know it because it doesn't cause any symptoms until it is too late. to start, and typically it is when we are starting dialysis. So I would say that this is not rare by any means. Actually, kidney disease is the fastest growing disease in the world right now. Yeah.
Yes, I know. It's when you hear those statistics, it makes you realize it's not that rare, actually. And you've just touched upon it, but the second myth that I've heard is that you always know when you have kidney disease. Is that true?
Yeah, so it depends on what kidney disease people are talking about. So if they have kidney stones, that does not necessarily mean kidney disease. You can have kidney stones with a normal kidney function, and you will feel the kidney stone passing through the kidney, the ureter, the bladder, and eventually out. But if we're talking about regular chronic kidney disease that is from high blood pressure, from diabetes, smoking, um, NSAIDs, then no. As the GFR is dropping, as your kidney function is dropping, we do not feel any symptoms whatsoever. We start to feel symptoms when kidney function goes below 15 ml per minute. Normal should be 120. So that gives you some perspective as to where we should be and where we start to see symptoms.
Very interesting. Yeah. And then the myth three is dialysis is the only treatment for kidney disease.
Yeah, so it depends on the patient, depends on their views, religious beliefs, and also depends how healthy they are. Kidney transplant is also an option, but kidney transplant is the biggest surgery a body can undergo. So not everyone is healthy enough to go for kidney transplant evaluation, or even to be listed for kidney transplant. There is always an option not to do the dialysis and do palliative care. And we call that maximum medical management, meaning we are taking care of the kidney disease, the complications that come along with kidney disease with the medications, short of doing dialysis. Of course, that means that the lifespan of the patient is pretty short. If we are talking about maximum medical management or palliative care in kidney disease patients, but those are typically patients who have other health problems. Either they are very old, either they are very sick with heart failure, with cancer, with liver failure. So we might increase their quantity of life by a few months, but will certainly reduce their quality of life. So when that distinction needs to be made, or when we are at those crossroads, then we recommend maximum medical therapy. So kidney disease, if it reaches to the point where it is, we call it chronic kidney disease stage 5 or end stage kidney disease, there are three options: uh, transplant, maximum medical management, and dialysis.
Okay, thank you. And then the last myth that I have is that you do need two kidneys to live, and most people actually do have two kidneys only.
Yeah. So yes, most patients do have two kidneys. They are born with two kidneys. There are rare anomalies where you can have a horseshoe kidney, which looks like horseshoe. We have patients who are born with one kidney. But when we transplant somebody, and it's an adult kidney that is being transplanted, we transplant one kidney. So you can live with one kidney a healthy life. There are living donors that donate kidney as well, and those are, of course, they are healthy patients, healthy people, no other medical problems, and they donate the kidney and they live a very healthy life. So yes, we can live healthy with one kidney.
And what about with kidney transplantation? I've heard that you can actually have three kidneys with the addition of the transplant kidney.
Yeah, so we don't take out our native kidneys. We call our own kidneys as native kidneys. We don't take those out. We just add a third one. Um, the old ones are not working, so they are not contributing to anything right now. It's only that third transplanted kidney that is contributing to maintaining your homeostasis.
It is very cool, very interesting fact for everyone to learn today. And then the next question that I have is, what advice would you give students who are interested in internal medicine or nephrology, but unsure of what path to take? How would you recommend that they explore their interest at this stage?
For students, I would say whether they are thinking about internal medicine or nephrology, it is all pathophysiology. So if you love pathophysiology, if you love solving cases, I would recommend to get more exposure by when you are in your third year, fourth year, to get more clinicals in internal medicine, maybe a clinical or a two in nephrology. And when you are a resident, I think the second year is where most of us start to have an idea which one we like. My personal thought was for years and still is I want to do something that I can do when I'm half asleep. And I want to do something that when somebody calls me, I'm not mad about it or tensed about it. All right, I got it. I'll take care of it. And I'm happy about it. So this medical burnout that we hear so much these days, it is from many reasons, but one of that is having unrealistic expectations from your future career. And I feel that as you become consultant, there is more responsibility on our shoulders. So thinking that being a consultant, we're gonna have less burden, uh, have more time on our hands than an internist. I don't think so. That's true. There are ways where we can have a good family work balance. But the biggest is when we call other consultants and they're not happy that we're calling them. So to me, that is a big red flag that, I mean, this is why you came into this field. You know, you're passionate about it. So let's take care of it. Let's do it. So for residents, I would say, think of something that you can do in half sleep. You're sleeping, you're on call, they call you, and you make a correct judgment when you're half asleep. And second is something that you like doing day in and day out. Only way
That's
to know is
great.
to experience it. Yeah.
Yeah, that's wonderful. And speaking of the work-life balance, how do you stay grounded, have that balance, and manage stress outside of medicine?
Oh, I wish I could give I wish I could give you fantastic answers on that. But um, so we are so I'm not stressed about work. There are certainly there are days that are more stressful. There are days that are more long. There are weeks that are more longer than others. But you gotta find what you like. If you like reading a book, if you like working out, if you like cleaning the house, if you like driving, whatever is your hobby, you gotta find. If your hobby is to just sit and watch movies, if your hobby is sleeping, it doesn't have to be an active activity. Um, you gotta find time for that. Initially, it is difficult as we are getting into these fields. We are starting families, we have kids, so they take precedence. But uh, I would say never forget your other passion besides medicine. That would help.
That's wonderful. Thank you for that advice. But yeah, that ends the questions that I have for you today. I really appreciate all your insightful answers, and you've left us with some interesting things to think about. But now we can move on into the case study part of today's webinar. So I'll go ahead and share my screen, and we can go through that and then go through the slides that you have prepared for us today.
Okay.
So let me share my screen. Perfect. And you can just tell me, and I'll keep moving the slides along.
Okay. So we can start with the second slide. So I think we touched a little bit about what is nephrology. And like we talked that, nephrology is all pathophysiology. So you would be dealing with a lot of other systems of the body along with nephrology. So whether you have hypertension induced heart disease and kidney disease, heart failure induced kidney disease, or vice versa. There are a lot of autoimmune diseases like lupus, Sjogren's syndrome, ANCA vasculitis, Goodpasture syndrome. I mean, you can go on and on and on, where multiple organ systems are affected. And of course, we take care of patients who start dialysis, and not everybody sees transplant patients. In our practice, there are two providers, two physicians, and two nurse practitioners who see transplant patients. So it depends on which kind of practice you are in. And yes, we treat both acute and chronic kidney conditions. So acute would be your acute kidney injury, which is acute renal failure, meaning your kidney is failing pretty rapidly within days to weeks. Chronic kidney disease is when your kidney function is low for more than 3 months. Acute kidney conditions also include electrolyte imbalances, acid-base imbalances. So it's a mix of all. So we can go to the next slide. Yeah, so since we don't have any symptoms, how do we figure out whether we have kidney disease or not? It is by blood tests. It's a simple blood test. We call it Basic Metabolic Panel, BMP, or Renal Function Panel. Anybody can check it. It's very simple. Most of the labs are equipped with the reagents to run these tests. All primary care physicians, urgent cares, ERs, they have this. And the way we do is we check creatinine in blood. Now, creatinine is produced by muscles, and kidney gets rid of it every day. So everyone's creatinine is different. It it is based on muscle mass. So somebody who is 15-year-old female versus 80-year-old female, different muscle masses. 20-year-old guy versus Arnold Schwarzenegger versus a 75-year-old old guy. Sorry about that. How do we account for those confounding factors? So we put serum creatinine in a formula. That formula includes patient's age, height, weight, sex, and it corrects for those and gives us a number. And that number is called eGFR, estimated glomerular filtration rate. Glomerulus is like a cup at the top of the nephron, and that's where all the filtration is happening. The reason it is estimated is because we are using a formula to estimate it. So the higher the creatinine, lower the GFR. So it goes in opposite directions. Normal GFR is 120 ml per minute per meter square. And creatinine normal values vary quite a bit, from 0.5 to 1. But again, I would not go by the creatinine value. I would go by GFR. So that's how we figure out whether patient has kidney disease, whether patient has acute kidney injury, and also that basic metabolic panel gives us some of these electrolytes, not all of them. It gives us potassium, sodium, calcium, and bicarbonate. Then urine test, we check urine analysis. We check for protein leakage or blood leakage. Different diseases present different ways in the urine. So that gives us an idea of what we are dealing with. Lately, there have been a lot of genetic testing. There is a panel called RENA-SIGHT, RENASIGHT, that tests genetic markers for kidney diseases and close to 300 kidney diseases. That has been just become available over the last 5 years. There is some personalized medicine out there, not a lot right now. What I mean by that is understanding how a person metabolizes certain medications, and whether we need to give a higher dose or lower dose for the desired therapeutic effect. So that is in the works. It is not available in a large scale by any means. Imaging, the easiest thing for kidneys is ultrasound. Very easy to do. You can get it done anywhere. Almost all ultrasound techs are very efficient in capturing the whole kidney. Most of the radiologists are really good in capturing and reading those kidney ultrasounds, whether there is any cyst, any stone, anything else. So that is typically what we start off with, is a kidney ultrasound, and from there we go if we need to do any other testing. Okay. So if we are looking at autoimmune disease, let's say, like we were discussing on the last page, whether patient we think has lupus nephritis or ANCA vasculitis, or in kidney transplant patient, if we think patient has a recurring disease, maybe that is the disease that caused the kidney failure to begin with, and we think it is coming in the transplanted kidney. Or we want to diagnose kidney rejection. There are two types of kidney rejection, and each have different classes. So each has different treatment options. So that's when we decide to do a kidney biopsy. Kidney biopsy is where we take a foot-long needle into the back. Patient lays on their tummy, and we get two small pieces out. We typically want at least 20 glomeruli, so 20 nephrons out of 2 million. We only biopsy one kidney. We do not biopsy both kidneys. The thought process being that if it is a systemic disease causing kidney issue, it would be affecting both kidneys equally. And the other big reason is that kidney biopsy comes with its risks, which is the biggest one is bleeding. So you don't want two kidneys to bleed at the same time. Those are some of the indications for kidney biopsy. When we see a regular CKD patient where they have been diabetic for 20 some years or have high blood pressure for 20 some years, uncontrolled, has diabetes in the eye, they have heart issues. In those patients, we know that most likely they have kidney disease from those underlying diseases, and going for a kidney biopsy would not add much to the treatment and would put them at unnecessary risks. So that's the time we don't do a kidney biopsy. Dialysis, yes, when the kidney is not able to handle what the body needs, then we start dialysis. And when you go on your rotation, you will hear about an acronym AEIOU all the time. A is acidosis, E is any other electrolyte abnormality, O is volume overload, I is ingestion, any toxins, whether it is alcohol or any other drugs, and U is uremia. So when we start to see issues like that, that means it's time to do dialysis. AEIOU. And of course, transplant. The most definitive treatment for kidney disease, if patients can tolerate, is kidney transplant. It is done by, in the United States, it is done by transplant surgeons. In other countries like India, it is done by urologists. Okay, so very different set of skills involved. Yeah.
Thank you.
We talked about this a little bit. Creatinine 0.6 to 1.3. The reason the range is so high is because we are dealing with all adults here. Anyone who's 18 and over, weight from anywhere from 80 pounds all the way to 500 pounds. So everyone has different muscle mass. So I typically don't go by creatinine, I go by EGFR. BUN, typically we use BUN in conjunction with creatinine. BUN by itself can be elevated in other conditions that is not associated with the kidney. So I would always focus on creatinine and GFR rather than BUN alone. Potassium normal is 3.5 to 5. You're correct. Depending on the lab, it could be 3.5 to 5.1. Bicarb also is 22 to 28. And if there are diseases and drugs that can make potassium go up or down, and there are diseases that can make the bicarb go up or down. So when we see that, we try to figure out what is happening, where it is happening, and how to fix it. Yeah, EGFR, the bulk of the talk. So if you guys focus on the right, this is a more newer version of risk stratification in kidney disease patients. So there are many formulas that tell us about EGFR. Initially, these formulas were created to estimate your kidney function as accurately as possible once the kidney function is below 60. Okay. When the kidney function is above 60, it loses its accuracy. The reason I say that is when you look at some of the lab results, it will only say EGFR of more than 60. It will not actually give you an actual number because it loses its accuracy. So those lab companies, they will not give you an exact number. So it could be 61 or it could be 120. They will all say is more than 60. So I like this table on the right side because it goes all the way up to more than 90. Because 90 to 120 EGFR is chronic kidney disease stage 1. If you have protein leakage, then we know that there is kidney damage, there is glomerular damage, that cup that we talked about. So you do have kidney disease. It's just it is very mild. And then as you go down, every 30 points, your stage changes. So from 90 to 120 is stage 1, 90 to 60, stage 2, 60 to 30, stage 3, 30 to 15 is stage 4, and below 15 is stage 5. The colors tell you the risk of progression of kidney disease to end-stage kidney disease. So somebody who's on the extreme left and top, their kidney function is pretty close to normal. They don't have much protein leakage. They'll probably be okay long term. somebody who has kidney function, even if it is close to normal on that top part, but they're on the right, meaning they're spilling a lot of protein, they are at moderate risk. And as you go down, the risk becomes higher and higher. So it tells you the complexity that we have to look at a lot of things to tell a patient what kind of kidney disease they have, what stage of kidney disease they have, what are their risks of progression, and what are their risk factors and how to fix it. Next slide, please. We can skip this slide. I have a case that we can talk about.
Okay, great.
I wish that everyone who has GFR of more than 60 for more than 3 months would be referred to a nephrologist. But in reality, internal medicine internists, they are more than capable of taking care of chronic kidney disease stage 2, stage 3 patients. So stage 2 is when GFR is 60 to 90. Stage 3 is when GFR is 60 to 30. We typically do not see any complications from kidney disease that early on, and unless there are some circumstances and some cases where we can. So typically we see a patient when the kidney function goes below 30 in a simple CKD patient. Now, the reason that is that we refer a patient for transplant when the kidney function goes below 25, and the patient starts dialysis when kidney function is below 15. So we need time. We need time to first diagnose their kidney disease, figure out if it is reversible, put them on appropriate medications, and if we cannot slow the progression down, then to get them for transplant evaluation. And of course, persistent proteinuria, hematuria, as you saw in the previous slide, even if the kidney function is normal, but there is protein leakage in the urine, yes, it needs to be evaluated. Doesn't matter the age. Uncontrolled hypertension despite medication, I agree with that. There are electrolyte abnormalities that we see. Some are congenital, some are acquired, some are from disease states, some are from medications, some is from food and over-the-counter herbal supplements that patients take. So I agree with that as well. Kidney stones, typically we send patients to a urologist for kidney stones. They are the ones that actually take the kidney stones out. They are the ones that put the stents in. So that is typically dealt with by a urologist. And so does abnormal imaging if it is a big cyst, if it's a complex cyst, if it is a mass like renal cell cancer, they are sent to urologists. Um, yeah, I mean, I think we have touched every single point on this slide. Uh, if you don't mind, I want to share mine and we can go through some
Of
things.
course.
Let me see. Okay. Can you guys see this? See the slides?
Yes, yes, we can.
Okay. So I prepared this. We already went through this nephrology study of nephrons. Nephron is a single working unit of a kidney. We have 1 million nephrons in each kidney, so 2 million together. Nephrologists routinely take care of all these issues that we already talked about. This is what a kidney looks like. Looks like a bean, about 10 to 12 centimeters. They are located on each side of the spine in the back. Can you guys see my cursor?
Yes.
Okay. And imagine this 12 centimeters kidney having 1 million nephrons in it, and each nephron having a blood supply, and each nephron having a drainage, because nephron will produce urine. So this is a very complex, very dense organ. And the red one is through which the blood goes to each of the nephrons. You cannot see nephrons with your naked eye. The clean blood comes back, and this is where the urine gets collected in these calyces. From these papilla goes to calyces, from calyces into the ureter, and this goes into the bladder. So this is where we see, this is a nephron. This whole yellow squiggly noodle is a nephron, and each nephron has a blood supply. This is a nephron in a little bit more magnification. This is the cup that I was talking about. That is your glomerulus. This is where the blood comes, gets filtered through the glomerulus, and then the clean blood goes back. So this is where the glomerular filtration rate comes into play. We talked about the role of the kidneys. We talked about this a little bit. The most common causes in the United States is high blood pressure, diabetes, autosomal dominant polycystic kidney disease, and pain pills. And the reason I said ADPKD is because that's what my case is about. These are the stages of kidney disease in a different way. Patients like this, where you can show them how full their kidneys are. Stage 3 is when they're half full, and stage 5 is when they're almost empty. This is from National Kidney Foundation. But it says the same thing. GFR 90 or higher is stage 1. Stage 2 is 90 to 60. Stage 3 is divided into 2, stage 3A and B. But when you combine them, it is 60 to 30. From 30 to 15, and less than 15 is stage 5. So the biggest risk factors: diabetes, high blood pressure, obesity, cardiovascular disease, smoking. Just these top 5. These all 5 are rising in the world. I think we all agree with that. And because of that, the kidney disease is rising. The problem is that 80% of them don't even know that they have kidney disease. Minorities are at higher risk of certain kidney diseases, and of course the age. And if you have a family history, that puts you at higher risk. We talked about this already, diagnostics. We talked about markers of kidney function. Kidney transplant, we'll talk about this a little bit later. Just wanted to go with the case. So this is a guy, Mr. PL, who's a 45-year-old, history of autosomal dominant polycystic kidney disease, diagnosed at the age of 20, who started seeing nephrology 5 years ago when his creatinine was 2.5, giving estimated GFR of 30 ml per minute. Over past 5 years, his kidney function has gone down to 10 ml per minute per meter square, and now he's having nausea, vomiting, and swelling of the legs. His blood pressure is also elevated to 160/90. So this talks about, let me see. Anyways, so this talks about those AEIOU that we were talking about. Patient having uremia symptoms, nausea, vomiting. He's having volume overload, swelling of his legs, blood pressures are elevated. So it is time to start dialysis, especially when his kidney function is below 15. So this is what a normal kidney looks like. This is what a polycystic kidney looks like. These are all small cysts that are filled with urine. There are hundreds and hundreds of cysts, and they get bigger. The kidney gets bigger. The bigger the cyst, the bigger the kidney, the faster the decline in kidney function. Are you guys able to see that?
Yes.
Okay. So what are the next steps in this gentleman? So the next steps would be managing the complications of chronic kidney disease, like hyperkalemia, which would be potassium more than 5.1, hypervolemia, which is swelling of his legs, and having high phosphorus, having anemia because our kidneys also secrete a hormone amongst other hormones. It secretes a hormone called erythropoietin, which goes to the bone marrow and makes our bone marrow make more hemoglobin. When the kidney function goes below 20, we ask the patients to start getting ready for dialysis, and I'll show you what that means. And when the kidney function is below 25, we refer the patient for kidney transplant. The reason we refer patients for kidney transplant earlier than starting dialysis is because it takes roughly a year, if not longer, for the patients to be evaluated and be made active on the kidney transplant list. An average wait time for the kidney transplant in South Carolina is 3 years. It is very center specific. Some of the centers, let's say in New York and San Diego, the wait time can be as much as 10 years on a kidney transplant list. So we need that lag time. We need that time where patient can be evaluated, get on the list, and hopefully gets transplanted before they get to dialysis. But our gentleman, he did not go for, he was not able to be evaluated for transplant on time. So he started dialysis. And what we mean by getting ready for dialysis is this. On the left side is your AV fistula, and on the right side is your AV graft. AV fistula is when you connect your own artery to your own vein and create a direct connection between the artery and the vein. This vein all of a sudden starts to get a lot of blood flow, gets bigger and thicker, and we call this fistula. This is what we use to stick needles when patients are on dialysis. This process of becoming thicker and bigger is called maturation. Maturation takes up to 3 months. Getting a surgery like this, it is a vascular surgery, can also take up to 2 to 3 months. So we need to anticipate that patient would require dialysis 6 to 9 months down the road, and we need to start that process right away. And that's why we start the process of getting ready for dialysis when kidney function goes below 20. Now, in some patients, their veins might not be big enough to begin with, that they can become even more big and mature to do dialysis. So we put a piece of plastic. We call that a graft. This is the piece of plastic. It is a connection between artery and a vein, just like there was a connection here. And then we put needles in this part of the graft, which is connected to the machine. Typically, this can be done and ready to use within 6 to 8 weeks. Again, we need the lag time. So we need to prepare this not when we are ready to start dialysis, but few weeks to months before. So these are the two main types that we want the patients to get. They have reduced risk of infections and blood clots. But of course, there are some patients who don't get any of this, and they end up on dialysis with a catheter. This is a dialysis catheter. It comes under the skin, goes all the way under the skin, and then here it goes into your IJ, your internal jugular, and then the tip is at the junction of the vein and the heart. We use this to do dialysis. This can be placed within hours, and we can start dialysis within hours. The bad part about this is that it causes a lot of infections and blood clots. So we don't want this to happen. And that's why the preparation. Now, what happens is when you connect those needles to your fistula, The blood goes out into the filter, gets cleaned, and then the same blood comes back into your fistula and then goes to the heart and gets pumped. Typical dialysis is 4 hours at a time, 3 days a week. This is what a dialysis machine looks like. I think Sham saw this machine with me briefly. This is where the blood is coming, getting here. There is a filter right here. I'm sorry that it got cut, and then it goes back to the patient. So some of the statistics we were talking about, number of patients, the number of patients on the transplant list as of 2023 are 88,000. Patient added to the transplant list each year is 25,000. Number of transplants that we do each year is 25,000. So so 1 in 4 patients who are even on the list will never get transplanted and they will end up dying. So that's where we talk about organ donation. These are the list where we are getting the kidney from a cadaver, from a deceased person. Number of patients starting dialysis in the United States is 130,000, and patients, total number of patients who were on dialysis in 2020 were 800,000. So it shows you number of patients at any given time on dialysis, close to 1 million. Close to 100,000 start each year dialysis, but only 25,000 get transplanted. So overwhelming majority of your patients end up on dialysis permanently. So what are the types of transplant? This is the most common, deceased donor kidney transplant, where you are put on the list. Then if you are a good patient, good recipient, then you can have a person who can donate a kidney to you. Could be a family member, could be a neighbor, could be a friend, or could be altruistic. Somebody who just comes out of the blue to give you a kidney. We have had cases where people saw Facebook posts and they don't even know the patient and they end up donating the kidney to them. There's a whole process behind it. It's not that simple, but it has happened. And the other thing is called paired exchange, where you have a donor, but that is a donor that does not match you. So the patient and the donor, they are put in a database, and then they find the next pair where the donor for patient number 1 might be a good match for patient number 2, and the donor for patient number 2 might be a good match for donor for patient number 1. So that is called paired exchange. And this is called a chain. So between the two, this is a 2-chain exchange. The longest has been 35 chains in the United States. So the donor kept on donating to the next person, and the 35th, I think, donor donated to the to the pair of the first person. So that is also that happens. This is the picture of the first kidney transplant ever between 2 identical twin brothers in 1954 at Harvard. And the guy Ronald, who gave the kidney to his identical twin, he actually passed away in 2010 at the age of 79. And Dr. Murray, who did this transplant, got the Nobel Medical Prize for that. So just wanted to show you guys this. This is a pretty cool picture of the first transplant, successful transplant. This is where the transplanted kidney goes. These are our native kidneys. They still have the ureter coming to the bladder. This is where the transplanted kidney goes, and it has its own ureter coming to the bladder. So the patient has 3 kidneys. Some patients, they fail this kidney, then they go for a second transplant, and that goes on this side. Some patients are going for the 3rd transplant. If they go, then the surgeon need to decide which of these 2 need to come out, and then they put the third transplanted kidney there. So Mr. PL, I saw him. He is now 1 year post-transplant. His creatinine is 0.7. Kidney function is close to 80 ml per minute. Now remember, our normal kidney function is 120. That is when we look at both kidneys together. So if we remove one kidney, 60 of that 120 is lost. But the remaining kidney is healthy enough to become hypertrophied and compensate for some of the loss. And in some patients, we do see that they can improve their kidney function a little bit more than 60. This gentleman, he got a kidney from a young donor, so was a pristine kidney, and creatinine is as close to as it can get. His acid base is fine. His electrolytes are fine. His blood pressures are very well controlled now. He has no swelling of his legs. But he takes 3 immunosuppressive medications every day to prevent his own body from rejecting that kidney. So those are your immunosuppressive medications. I'm going to stop sharing here. And those are some of the things I wanted to share, including the pictures. So any questions?
That was wonderful. Thank you so much for sharing this in-depth look into the case and nephrology. I know that I learned a lot, and I'm sure that our listeners did as well.
My pleasure.
Let's see. Okay, so there are some questions coming into the chat. So the first one we have is, what are some of the current challenges or inequities in the transplant system?
Yeah. So that is a very hot topic. I'm not gonna pretend that I know everything about it. There were some inequities that were taken out, especially for African Americans. The EGFR had a correction for African Americans, and that would push their GFR a little bit higher than general population. So if their GFR is a little bit higher, then they will be referred for kidney transplant later. So that was taken out after 2020. Second is every patient is referred at a different time for transplant. So the transplant wait time starts after the referral is done. And in some cases, it is not the patient's, how should I put it? Patient is not at fault that they were referred late. So why should they be at the bottom of the list when they have started dialysis many years ago? So we came up with this new idea where patient would get that time back. Doesn't matter when they are transplanted, because remember that average wait time is 8 to 10 years. So if somebody is already on dialysis for 8 years and they are referred now, they should get those 8 years on the list, versus somebody who was just started dialysis and now they are referred and they're active on the list. So those are the two main. There are many others where media has brought those issues to limelight, and the transplant community is actively working to figure those issues out.
Great, thank you for your outlook. And then the next question we have is, what does your patient population look like on a regular day?
So if we're talking about dialysis population, it is majority of them are African Americans and then Caucasians. We are here in Columbia, South Carolina, so there are not that many minorities yet. We are starting to see more Hispanics in our patient population. But the African American would be, they are at higher risk of kidney disease. So that would be a typical population.
Okay. And in terms of the cases that they come in with, what are the different treatments or the different diagnoses that you might give on a regular basis?
Most common is hypertensive nephropathy and diabetic nephropathy. Overwhelming majority of it is those two. They present with hematuria, they present with proteinuria, they present with um, um, worsening kidney function, and then all the other complications of CKD. So those would be the most common.
Okay, thank you. And then our next question is, what are some new technologies that you've seen in the field? Are there such things as artificial kidneys?
Yeah, so they are developing different types of artificial kidneys. They are developing kidneys that are as small as your iPhone, that can be implanted in the kidneys, in the body. So they are trying to make more effective dialyzers as well, the filters that are attached to the machine. Um, and then there are pig kidneys. We all have heard and seen that. So it is not easy to get a kidney from another species that our body's not going to reject. So to try to develop a kidney that does not have the antigens that our own body is gonna um, identify and then make antibodies against and then kill it. So I think between the artificial iPhone size kidney and pig kidney, I think we are much closer with the pig kidney to reality. Still, it's close to 10 years, if not more, before these can be approved nationwide. They need to show survival benefit than what we have already. That's what it is. They need to show survival benefit. If they are inferior to our current strategies that we use, then we have to go back to the drawing board.
Okay, that's really interesting to know.
Yeah. So
Well,
concept is there.
yeah.
So concept is there. Whether that
Mhm.
concept, second is whether that concept works. Then third is whether that concept works in a human. And then the fourth is if that concept works in the human, does it provide any advantage to what we already have? So we are on the second phase, kind of with both strategies. Yeah.
Okay. And based on that, how long do you think it might take for these kidneys and these technologies to be incorporated into practice?
Um, I would say at least a decade, if not longer. Um, having one place develop expertise is one thing, and then disseminating that expertise to all the other places is another thing. Um, Also, we need to make sure that when um, let's say pig kidney. If pig kidney is transplanted in New York versus a pig kidney is transplanted in Charleston, South Carolina, are the outcomes similar? If they are not, then why not? So those nuances need to be dealt with, and some of those nuances are time based. Can't do anything about it. You can have all the AI models that we want, but ultimately, when it gets into the body, that's when we realize what exactly is happening. So I would say at least 10 to 15 years, if not longer.
Oh, okay. Well, I think our last question then from our listeners is, are there any risks for choosing dialysis as the treatment?
Choosing dialysis as the treatment.
Hmm.
Okay. So when so one misconception is that we meaning nephrologists, we want to do dialysis. No, we don't want to do dialysis. We have to do dialysis. If we don't, the person would eventually die. So we have to, when we are talking to the patient, this is what we talk about. Yes, there is risks to everything, including oxygen and water. So is to dialysis. The biggest risks with dialysis is cardiovascular issues where you're pulling blood out so it can drop the blood pressure. It can cause arrhythmias. In very sick patients, it can cause cardiac arrest and respiratory arrest as well. Some of the more common side effects are nausea, cramping, because remember, we are trying to do what what two kidneys do in 48 hours. We are trying to do that in 4 hours. So there's a lot of changes that is happening in your blood, electrolyte wise, toxin wise, blood pressure wise, fluid wise. So yes, it will cause some side effects. Um, so those are the side effects of dialysis. Now, because of those side effects, if patients do not want to do dialysis, when we recommend doing dialysis, then I recommend hospice. I recommend palliative care in hospice, where we do maximum medical management until the patient passes away at home.
Okay. Well, thank you so much for answering our questions. As we approach the end of the webinar, is there anything else that you can share before we wrap up, keeping in mind that most of our attendees are pre-med undergraduate students?
Uh, um, it's a long road, right? It's a marathon. So I would I would recommend that you guys have heart to heart with yourself as to what you want out of this career. Um, that would be the biggest thing I would say, because what you don't want is to work so hard for something like this, and you are 32, 35 years old, and then you realize this is not what I was looking for. So I alluded this to earlier in the talk is um, understanding what you want out of medicine. If you are in for money and glory, I'm not sure that is there. If you think you're gonna get a lot of time on your hands as you're getting older, I'm not sure that is there either. Um, there is a lot of irritation and frustration in medicine, just like with any other field. So, um, understanding the perspective of other patients and physicians, and um, um, having a sense of empathy would go a long way in dealing with day-to-day issues once you get into your careers. But understanding why you're getting into a certain field is very important. And no one else can tell you that. It has to be you telling yourself, why am I doing this? So asking that question now versus when you're 35 would help you quite a bit.
Oh, great. Thank you so much for answering all of our questions, Dr. Katie, and we truly appreciate you being here with us this evening and taking the time to share your experiences and lessons with our listeners. To everyone who joined, thank you for being part of this conversation. If you have any additional questions, feel free to submit them on our website, and Dr. Katie will be able to answer them by the end of the month. And then a recording of this webinar will be available on our YouTube channel and our podcast that should be uploaded soon. As always, feel free to reach out to our PhysiLink team with the contact listed on our website. And on that note, thank you again for attending. Thank you to Dr. Kadian for being here, and we hope you have a wonderful rest of your evening.